Good afternoon and welcome to the weekly seminar series at the Dahdaleh Institute for Global Health Research. My name is Professor Mary Viktorovich, and I'm the Interim Director of the Dahdaleh Institute for Global Health Research. Today, I'm delighted to host Emmanuel Musa, who will lead today's seminar. It's titled Addressing Inequities and Access to Medical Countermeasures During Health and Humanitarian Emergencies, My Lived Experience. As is our usual practice, I'd like to begin by acknowledging the Indigenous land that we're on. And as this is a hybrid event and some guests are on different territories, I invite you to take the time to give thanks and respect to the land on which you are currently living and working. York University is situated on the traditional territorial area known as Tkaronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We acknowledge this as the traditional territory of many Indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is subject of the Dish with One Spoon Wampum Belt, a covenant and agreement to peaceably share and care for the Great Lakes regions. So let's begin with an introduction to our speaker. Dr. Emmanuel Musa is a medical doctor, clinical scientist, epidemiologist, and public health expert. He's previously served as a team lead for the High Impact Epidemics for the World Health Organization's Health Emergencies Programme in Geneva, Switzerland, and a senior medical officer for emergency risk management. Dr. Musa has over 2 decades of various operational and leadership positions within the WHO related to disease outbreaks, emergencies, humanitarian aid, the polio eradication initiative, primary healthcare, and strengthening health systems in multiple countries. He holds an MD, MPH, and Master of Science in Health Systems Management from Liverpool in the UK. He's a PhD candidate in health research at the University of Bath, also in the UK currently. So in today's seminar, Dr. Musa will discuss the access inequity to potentially life-saving medical countermeasures, which are strategies and tools used to prevent, treat, and mitigate health threats. He'll draw on his extensive career in global health advocacy and research, particularly within the framework of the WHO. He will offer practical recommendations on how we can enhance our preparedness for health and humanitarian emergencies with a focus on expanding access to medical countermeasures. So this is a 1-hour event that will end at 2 p.m. We'll start with a 20-minute presentation by Dr. Musa, followed by 30 minutes of questions and discussion. And we'll then wrap up and conclude the seminar around 1:55 p.m. So just some general reminders to please note the seminar will be recorded, and to mute your microphone unless you're presenting or asking or answering a question. And also please use the raise hand button or chat function to ask a question. I'd now like to ask Emmanuel to begin his presentation. So over to you, Emmanuel.
Thank you very much, Mary, and thank you very much, everyone in the room and everyone connected online. The topic of my talk today is up there, so I'm going to actually give us a lived experience. This was one of the emergencies, well, many emergencies that I participated in while I was working at the WHO. This was the Tropical Cyclone in Mozambique in 2019. But before I go on, I'd like us to be on the same page on certain issues. First, I'd like to talk about what we mean by medical countermeasures. When we talk about medical countermeasures, these are actually a set of tools, strategies that we use to address health threats during emergencies, and there are a wide range of them. They include vaccines, the medicines, various kinds of medicines that we use, diagnostic tools, personal protective equipment, medical devices, even the public health measures that we implement. I think our experience recently in COVID many medical countermeasures were applied. As you can see there, it includes quarantine, the lockdowns we had, social distancing measures, travel bans, and all of that. And then even some of the measures we have in infection prevention and control, for instance, these are all medical countermeasures. So in fact, this is a wide range of tools, resources, and strategies or approaches that we use whenever we're faced with emergencies. So let's get down to this particular emergency. I chose this emergency because, yes, COVID has showed us or has revealed to us some of the problems with access to medical countermeasures. But I wanted to look at the situation even before COVID. So we understand that these are issues that have been there long even before the pandemic that were not addressed. And within the pandemic, we experienced the same problems again, even at a larger scale, because all parts of the world were affected. So if you look at this particular emergency, which happened in Mozambique, it was caused by a cyclone. A cyclone is like a hurricane, a major storm. Maybe before I go on, my role was as an EPI team lead for WHO, epidemiology team lead for WHO in the response. So I led the EPI team on the ground in Beira, Mozambique, where it was. Beira is located here. It's a port city just by the Indian Ocean in the country known as Mozambique. Mozambique is located in southeastern part of Africa, just adjacent to the Indian Ocean. And the neighboring countries include Tanzania in the north, Malawi, Zambia, and then Zimbabwe to the east, and then you have South Africa and Botswana to the to the west, and then to the southwest and south you have Botswana, even Eswatini and South Africa. So, like I said, the cyclone made a landfall in March, and you can see the trajectory here of the cyclone. And so the most affected provinces are these four. You have the Sofala, where you have the Beira, and then Zambezi, Manicaland, and then Tete. So these were the most affected provinces. Nearly 3 million people were affected, and more than 100,000 homes were destroyed. Hundreds of thousands. This was estimated to be well over 200,000 people were displaced. Over 600 deaths were recorded within the first 2 months, and more than the destruction was valued at over $700 million by the UN. So it was a major disaster. In fact, that disaster has been shown to be the most severe tropical cyclone that had ever hit Africa. If you look at this picture, was from World Vision, and it represents what some of the affected communities looked like in the immediate aftermath of the disaster. Because of the torrential rainfall and storm, many houses were submerged, as you can see. And of course, a lot of destruction happened: electricity, all infrastructure, water and sanitation, food was destroyed, transportation was affected, communication breakdown. Everything came to a standstill. I remember when we got to the ground, we could not use our cell phones, so we had to use radios. We had to set up emergency communication mechanisms to be able to communicate even amongst ourselves. So there was a total blackout, and it was really bad. Of course, you had many people who had been injured. There were people who were drowned and pulled out of the water. Of course, emergency rescue activities had already started, initially with the local teams, and then the international teams were arriving and joining. People who had experienced trauma were also receiving trauma care and all of that. And within 2 weeks, I think we started seeing cases of acute watery diarrhea, which was eventually confirmed to be cholera on the 27th of March, 2019. Within the course of the next 2 months, we were able to record nearly 7,000 cases and 8 confirmed deaths. So what I'm trying to say is that the picture I'm trying to paint is that we had a cyclone which resulted in flooding and devastation, and we started seeing the health consequences and humanitarian consequences of that disaster. That's the picture I'm painting. And we had to deploy our teams, we had to deploy medical countermeasures to fight this situation. So what medical countermeasures were deployed? Of course, because of the various needs based on the needs assessment or the rapid needs assessment and risk assessments that were conducted, we were able to deploy temporary shelter for those who were displaced. We were able to deploy medical teams to treat the injured and those who had other emergency medical conditions. Of course, because of the devastation and losses and all of that, we needed mental health and psychosocial support. It involved a lot of logistic support. You saw the scenario, and you need to pull people out of the waters, out of damaged homes, out of rubble, and many other things. And then when cholera came, we had to deploy all of this. So it was a huge operation. And to do that, we needed resources and infrastructure to coordinate. So we established an emergency operations center and equipped with all the communication and all other resources that we needed to respond. And we were meeting in the center alongside so we had a structure that looked like this. We had, on one side, we have the government structures for responding to the emergencies, what you have here. And then we had the international committee that had come to the country to provide support. So this was how we were organized. If you look at the international teams, we had the team of partners, we had the humanitarian country team, and then we had the working committee with the secretariat, and then we had these various working groups. The working groups were led by international organizations that had mandates under the UN or international health or other international, organizations with the mandate to respond to these areas. For example, of course, health was WHO, education was UNESCO, water and sanitation, you have Oxfam and all the other UNEP and all of that. Food security, you had FAO. So, and we had many other international organizations other than the UN organizations within this clusters. So we call them clusters under these working committees. And we met daily at the operations center. We also had the government counterparts. Okay, they had the emergency coordination agency and all their organs, and all of these worked under these sectors. So it was an government intersectoral response, bringing people from different sectors to meet all of the needs. If you look at this, it gives you a picture of what most of the needs were, and we had teams on the ground to respond to each of the needs. So we were here predominantly to deal with the health consequences. The cholera outbreak, of course we had other conditions. There were measles cases, we saw increasing cases of malaria as we went on in the response. So today we're talking about inequities. And when we talk about inequities, we're actually talking about the disparities that existed in the deployment of the health resources, the supplies that we had, the disparities in the outcome that we observed, and all of that. So I'm going to talk a little bit about that. Now, if you looked at the map I showed you earlier on, there were areas that were remote and isolated. Okay, there were urban areas, there were rural areas, there were even before the flooding or before the disaster, there were areas that we realized that there were delays in receiving essential supplies and healthcare services. When the temporary shelters came, they started with Beira, but there were areas that were far away from Beira, you know, hundreds of kilometers, like an area called Buzi, which was in another province, in Manica province. It took a couple of weeks to even set up the first shelter, for instance. And these guys had to do their own thing. They had to look for their own places. It also contributed in loss of lives, you know. And usually in situations like this, the most vulnerable are most affected. I'm talking about women, children, and the elderly. So before the international support could reach those places, or before even the national teams could get to those places, because of the fact that community capacities were very weak, there was nothing on the ground, basically, to respond to this magnitude of disaster. You reach them late with services, with essential supplies, even food, you know, and so it was serious. There were also areas that, in areas that were closer to where the landfall happened, you could see more destructions in health infrastructure. For instance, more hospitals, the key referral hospitals were all damaged. Each of the provinces had at least one referral hospital. The one in Sofala province in Beira was complete, including the theater was destroyed, and many others. Okay, so we saw a lot of damages in places that were first hit, and in other places, and we found out that in areas where more damages happened to the health facilities, the people received less care or less attention. There were areas that also had pre-existing security risks and access limitation because of communal conflicts. Okay, and when the disaster happened, you know, there was tension. People were upset. They're angry. There's no food, and they didn't think that they were getting adequate support from the humanitarian response efforts, and so some of them became hostile communities, and we needed to do security assessment, risk assessments before moving teams there, or else I'm sure you have seen places where health workers or international responders are attacked by local communities. So the risk was there, and that further compounded access to health services. And then we had overcrowded places. We had, within a month or two, we were able to establish about 135 temporary shelters across the affected areas, accommodating over maybe 150,000 people, but it was not enough. Okay, and you can imagine the challenge of giving them or supplying them food, non-food items like water storage containers, cooking utensils, soap, and things like that. Those are what we call NFIs, okay, non-food items. Providing them with adequate water and sanitation was a huge challenge. These countries' official language is Portuguese. Many of the teams, especially the international teams that went in, are not Portuguese. They couldn't speak the language. So this was a barrier in giving, so you had to work with people who were already there, who may not have been as experienced and who may not have all the expertise or capacities to provide relevant information and create awareness to the communities on what needed to be done. So this was also a challenge, and it could affect the quality of services and the reach of the services. I mentioned some of the gender inequities initially. We also saw that women, children, even girls had peculiar challenges, access to sanitary supplies, hygiene kits, and so on, even access to food. whenever you go to the shelters to give food, the men go for the food and the women are left behind. And you never know where all of the food collected by the men go to. So it was a challenge. So this is not to say that the teams did not recognize these inequities. There were many of them, but these were some of the key ones. And because of our time, I tried to summarize them. There were attempts to address these inequities as much as possible, and making sure that we integrated these approaches into the response process. When we met at the operation centers daily, we discussed them and put in place strategies to address them as we went on. So we had to enhance communication and community engagement, for example, in areas that had security risk and issues of access, areas that had not been reached, assuring them that there were plans to reach them, and listening to them, hearing from them, hearing their perspectives, and working with them, together with them, to create solutions and address those gaps. We had to, of course, look at how to prioritize and protect the vulnerable populations, like I mentioned. We had to have targeted outreaches to different places, had to reach areas. When we commenced the cholera vaccination, for instance, we had to start using helicopters to take teams, vaccination teams, to some of the places where bridges have been pulled down by the storms and all of that, and access. So we take the teams there by helicopter in the morning. They do the vaccination. We send the helicopters back to pick them back in the evening. That kind of operation. So so we have to really look at those kind of targeted areas and tailor our response approaches. I talked about emergency medical teams. Is a huge thing now in every humanitarian emergency and health emergency, where you have a team of health professionals with different skills and expertise. You take them in, so we can have an international EMT or a national EMT. Okay, this may be a government team or a non-profit organization or whatsoever. So you take that. It's like taking the hospital personnel and equipment and resources to the ground where they are needed. So they set up temporary shelter like a hospital, and they provide services to those who need them. Similarly, we needed to continue to do surveillance so we can monitor the situation and get updates on what is happening, and get quick reports about outbreaks that were coming and if there are any emerging infections. So we had to do all of that. So what lessons did we learn? We learned a lot of lessons, but we note that, yes, we seem to all be aware of the principles of humanitarianism we talk about all the time, but in practice and when you're faced with the situation, the story is usually different. All kinds of interests come to the table. The EOC is not an easy place to operate, so you have to have effective coordination, and you keep reminding people, including the responders, on the goal of the humanitarian. But we still think that even humanitarian responders can benefit from trainings that have to do with humanity and impartiality, even in the delivery of humanitarian response efforts. We have to use the phased approach in dealing with the communication issues, focusing first on the communities on the ground, involving civil society organizations, and then involving the influential persons and policy makers to ensure that there's a smooth communication of how the MCMs were distributed and how we were doing the work. I talked about vulnerable populations, but we learned that we must not leave anyone behind. We need to really look at low resource settings and make sure that in planning health emergency preparedness, we have strategies in place. So when we hit the ground, right from the periods of assessments, we begin to put in strategies in the response that will address those low resource areas and vulnerable populations. I've talked about intensifying advocacy for emergency preparedness. It shows very clearly that there was not adequate preparedness on the ground before the disaster hit. Very often, the magnitude will be unanticipated, and if you are not adequately prepared, you're gonna find it really difficult. I talked about collaboration earlier. You need to really do that, and it's got to be interdisciplinary. So it's not about doctors and nurses, but everyone, all hands must be on deck. And we need to really begin to think about the best approaches to do that. It's a big challenge when you are on the ground in the heat of emergency. We need to begin to look at these initiatives have started coming in from the experience of COVID, the last point. Okay, building local capacity to manufacture and develop some of the things. We have to bring in everything from PPEs to vaccines to treatments, including IV fluids. You know, the appropriate IV fluids for managing cholera. We have to bring in everything. And thanks to WHO for leading that effort. Within 1 week, all of this were in country. It's an expensive operation, but we think that things like IV fluids, treatments for cholera beds, vaccines should find somewhere, I mean, where we have a stockpile, knowing that these areas are at risk. There should be a stockpile somewhere in the region, okay? But these things were shifting from Europe. So, yeah. So these are issues that we really need to look at, because instead of 1 week, perhaps it could be 2 days or 3 days. I mean, and when we do that faster, we tend to save more lives. So now we're all researchers here, and I think there are opportunities for a lot of work to be able to understand how best we can deploy these MCMs that we already have. We need to begin to look at what are the challenges that occur in different settings, okay, that may be responsible for some of the challenges we're having. And if we don't fix them, we're going to see poor health outcomes. We're going to miss emerging conditions that may be caused by the emergency. So I'd like to talk about, you know, just when I was going to talk about AI for PEP, Professor Jude, who is the executive director, is here. So, so Dahdaleh Institute has started great work in that area already through this network. I'm sure you are all familiar with this, and which is looking into how we can deploy artificial intelligence and other data innovations to detect some of these conditions early and begin to respond to them, but not just detect, but predict where they are likely to occur. Between 2019 and now, there have been 3 cyclones in Mozambique alone. So it's going to happen and happen and happen again. Okay? So, and there are many other places, for instance, that are at risk of cholera across the continent. Okay? How can we ensure that we have a proper risk profiling of all the areas down to the communities and begin to prepare, pre-position all the MCMs that we need in the appropriate places, closest to the flash points or to the potential flash points, even before they occur. Perhaps that will give us a better response when they occur and better health outcomes. Now we are seeing increasing climate situations, and we are told that by 2030 it's probably going to double the incidences of climate events across the world. Okay, but low resource settings will be most hit each time it happens. Like areas like Mozambique and many parts of the global south will be most hit, and the health consequences will be more severe. So, but we know that for climate-related events, it's not only the global south, but even developed countries have suffered. We've seen what has happened in the United States, just next door. We've seen what happened with the wildfires here. We've seen what is happening in North America with the floodings and the earthquakes and all of that. So it's by everybody's doorstep, and it knows no boundary. So the earlier we begin to look at these things very seriously, the better. And so we need to begin to look at the current interventions we have, the current tools we have, the current MCMs we have, and see how we can improve upon them. And this gives us a lot of research opportunities. We are currently implementing different surveillance strategies, but which is the best, for instance, for climate-related events? Okay? How can we do the risk analysis and profiling to ensure that we have all the communities in high risk, we identify all the high risk areas and have all the communities already profiled even before the events occur, okay? And map where logistics or MCMs will be pre-positioned and all of that. I'm not sure there's a repository of information where we have all of these fine details ready for use when the emergency hits, since we don't know when it's going to happen. But for me, I think that would be the best approach to preparedness. Until we get to these fine details, we'll probably never be adequately prepared. And finally, I talked about the challenges of working together. It sounds very easy, but when you're in the heat of the response, you will understand. When you've been there, you will understand what I'm talking about. Okay? People come with organizational interests, personal interests, over and above the actual problem on the ground. And it affects the quality of the response and the results that you get. So if perhaps we research on the best ways to do this, to work together, even before we get into the emergency situation, we have simulation exercises, you know, and we're already used to how to work together. Perhaps when we find ourselves there, we will perform even better. So what are the way forward in terms of recommendations? These recommendations, there are many recommendations, but these are high-level ones that will help shape policies, because I'm talking about medical countermeasures. A lot will depend on policies, a lot will depend on finance, you know, and you know that most of the strategic planning, finance, and economic decisions are made by policymakers. It's high time we need to begin to also produce policy papers through our research to highlight some of these problems I've mentioned today and begin to create that global advocacy and solidarity for ensuring expansion of access to medical countermeasures and making sure that they're equitable. Resource allocation is key, like I've said. If you don't provide resources, you will not get there. You remember the comments of Obama when the COVID pandemic started. He said we had a beautiful plan for the United States of America, which sat on the shelf until COVID came. They had a robust pandemic preparedness and response plan, but it was never implemented as written. Okay, so I'm sure there were resource issues responsible for that because they needed to get approvals at different levels, including in the parliament to pass all of that through. But these are things we need to deal with before disaster strikes. We cannot overemphasize health emergency planning, like I said, for equitable distribution. I've talked about the financing mechanisms, but these financing mechanisms I'm talking about relates more to readiness. Readiness means you have put your preparedness planning in place, but actualizing or making sure that you have the capability to roll them out when the emergency eventually strikes. So that's what we're talking about. You need to have dedicated funding that you can just by the click of a button release the funds without any bureaucratic bottlenecks whatsoever. But we are not sure all of this is in place, and this has immense consequences for deployment of medical countermeasures in the field from experience. And then, of course, we've talked about research and innovations, which is our business here, and it also requires funding. We need to continue to invest in all of that. So I thank you all. Thank you. I think I overshot my time a little bit, but I hope I've been able to share this experience. It's a very passionate experience for me. I've had many others, from the Ebola experience in West Africa, from Liberia, Sierra Leone, Guinea, to DRC, and Marburg in Uganda, and part of Kenya on the border with Uganda, and many others, including natural disasters like conflicts in northern Ethiopia and so on. So there are so many of them, and we see recurrence of the same issues basically. And we have seen how we experience the same issues in COVID response. I think that's another topic for another day, our experience with COVID in terms of medical countermeasures. But I think we need to bring this to the front burner. I thank you all for your attention.
Okay, well, thank you so much, Emmanuel. That was really interesting and insightful. So let me begin with the first question. So the UN has recently come up with something, sort of an approach that's focused on anticipatory humanitarianism. And, you know, I was just thinking how, you know, you're saying a lot of the conditions continue to repeat themselves. So, for example, in Mozambique, it's a cyclone-prone area. Is there something about the infrastructure of, you know, the regions that tend to get hit hard that could be altered? For example, I'm from Winnipeg, and back in 1960, there was a really bad flood. They created a ring around the city. It's basically a floodway. And, you know, whenever there's a risk of flooding, they sort of open the gateways and to save, you know, the city from becoming flooded. I'm just wondering if any thought is being put into those kinds of infrastructure solutions or preventive efforts.
Do I respond or take more questions? Okay. Thank you very much. Yes, the lessons learned from every humanitarian situation is supposed to be used in the process of recovery, and then making sure that you put certain things in place in anticipation of the next disaster. And in a place like Mozambique, where we have experienced repeated cyclones, one would expect that these kinds of infrastructural modifications that you mentioned should be put in place in anticipation of these disasters. But I must tell you from experience, up until I left there, and I know that even up until now, I do not think that infrastructures are now being or have been put in place. I'm sure there are plans, because there was an evaluation of the Cyclone Idai and I think the Kenneth cyclones, and the report was shared with all the UN, all those who needed to know and implement, and we hope to see changes soon. But we haven't seen the changes yet, and we're seeing more cyclones happening. So I agree, that is the way to go, but we are not seeing actual implementation of these recommendations yet. But the recommendations to look at the infrastructures have been made already. Thank you.
Mary, you're on mute.
Sorry about that. So I guess when you're planning for disasters, or there's usually so many issues, I guess there's competing issues to address. So yeah, I could see how complex it could be. Are there questions in the room? Because I can't see if there are any hands up.
I have a question. I have a lot of questions, but pick your brain. You mentioned about co-producing solutions.
What?
Like producing solutions with the community.
Oh, okay.
Or co-designing solutions with the community. I was wondering if you can give me a quick example of one, what kind of barriers you faced, what kind of overarching goals or objectives were defining the solution in terms of sustainability. Because we have been working in Malawi and we hear a lot. We went to Red Cross in August, and one of their complaints was that simple solutions like washing hands and not educating communities to not openly defecate were not being followed because culturally that was what people were doing. So yeah, any advice around that?
Okay, thank you very much. I think this is one of the currently recommended approach to planning. Approach to preparedness planning to all kinds of health emergencies. We have learned from different health emergencies that without the community, you're going nowhere. And we have seen the roles that communities can play in making a difference in different kinds of disasters, be it disease outbreaks, be it natural disasters, be it man-made disasters, or whatever. Okay? The community has an important role to play. And that's why we need to build local capacities to do that. Now, what does that mean? It means that in every community, you have existing mechanisms of problem solving, no matter what the problem is. And I think as experts or as professionals, we tend to overlook all of it. If you look at the previous or the earlier disaster management plans that were done, they were top to bottom planning, so to say. But increasingly, we are saying, okay, engage the communities, plan with them. So you need to identify key actors at the community level and bring them to the table. They have their aspirations. They have the way they do things. We need to understand those things. And this has to be tailored to the environments or the areas where you want to provide your humanitarian response or emergency response. Okay? So even within Africa, there are so many countries in Africa, and there are some differences in their culture and aspirations as a people. You need to understand those peculiarities and plan with them to be able to deploy some of your medical countermeasures. And that is why you see that in certain communities you take certain approaches there, and it results in violence, or they reject your no matter how you think those measures are beneficial, they reject it. They can become hostile, and it can even be a threat to the responders. So we cannot overemphasize that. Communities must be involved. We must identify key people within the communities who have good knowledge and experience of those communities, who can sit around during the planning phases, and we get their input into all of those things, and plan, do the bottom-up approach to planning and preparedness. And not just for preparing. During the response, we need to involve them. So we need to involve local NGOs, civil society organizations, youth groups, women groups on the ground, in providing the responses. We need to engage them. We need to work with them, get the desired outcomes.
Okay, thank you. Thank you. Absolutely. The community surely has to be part of it. Harvey, you had a question. I'm wondering if you'd like to go ahead. You're on mute. Yeah.
Oh, hi, Emmanuel. Very clear, compelling presentation, and you outlined some very ambitious steps for getting people, organizations, even whole nations cooperating. But as you point out, and as our experience, it's a huge, huge challenge. So I wonder if you've got one or two examples of success stories and why it worked, because we get inspired and learn a lot by stories, success stories.
You want me to tell a story? Yeah, I'll tell you a success story. I'm sure during the Ebola outbreak in Liberia, during the initial stages, you saw how the community became hostile to the issues of contact tracing and isolating patients from the communities. And you remember in a part of the capital, this is actually a slum area in Monrovia, Montserrado County. They became hostile. It was even on CNN, and you could see how they attacked health workers, attacked an Ebola treatment unit, and all of that. It was all on. It was really bad. Now, how did we deal with that situation? We had to, we had to work with the community. We were forced to work with the community. The interesting thing in that area is that it was an urban community in the sense that there was no well-structured traditional institution. In most parts of Africa, for instance, the traditional institution is a good entry point, because traditional leaders are gatekeepers of all the communities. They are well respected, and when they speak, they are equally very influential. When they speak, people tend to listen to them and take their advice. But in some of these slum peri-urban communities where you have multi-ethnic, multicultural people living there, it was a bit challenging. That was the situation with the Montserrado. So what we did was to really x-ray that community and see what are the different groups and who are the leaders of the different groups. So we had people who were local transport workers. We had women groups. We had people who were residential association groups. In fact, we even had gang leaders, local gang leaders, because you'll be surprised that in some of those slum areas, the local criminal gang leaders are actually very influential. So we had to identify them and bring them in, had meetings with them, talk to them to see why they need to cooperate with some of the measures that were being implemented. And we had to engage them to help us with contact tracing. So we had certain agreements, and for example, we said, each time we suspect that there's a case, we will contact you, and with your support, we're going to do the contact tracing. We will isolate the patients with your support. So they will join the health team to go to the particular house, talk to the people, get the person into the ambulance and get to the treatment center. And then we send back the teams to work with them on daily basis to do the contact tracing for the 21 days. And it worked really well. Of course, we give them incentives for their time, which is I mean, they were spending a lot of time with the health workers because they were always with us. So they needed to be compensated for that. And it's really amazing to see how very little amounts of money can make a whole world of difference in communities like that. And that really should not be overlooked. So we engaged them, we involved them, and we saw the results. It became peaceful. We were able to do the work. We were able to track all the cases, do the contact tracing, and limit transmission of Ebola in those settlements. I think that's one story I can quickly remember, but there are many more. But the summary is that we need to identify the key influential persons, tailor our approaches, get input from them on the best way to do it, work with them to implement, and get the results we're looking for. Thank you.
Great. Well, yeah, the complexity of the situation on the ground, always a challenge, but it's great to hear you found ways to navigate it through the community. So yeah, again, we seem to keep going back to the community. Any other comments? We have about 5 minutes left. Any other comments or questions?
Yes, I'm just curious, Emmanuel, can you be able to bring this as to how you have been able to use this experience that you have learned in the field in the academic environment? Because some of these experiences, people do it that in the field unless you find yourself in that situation where you work with WHO, you don't practice this. And students don't get to practice this unless they lived it like you did. But the fact that you have been in the field and the academic area, how do you bring this experience to classroom?
Okay, thank you very much. I've had the opportunity, even while in WHO, to teach classes of epidemiologists, different kinds of health workers, people working in IPC, people, even people involved in laboratory diagnosis, people involved in risk communication and all different groups, training them on how to implement these practical approaches in the field. And so that's one approach. So through organized training programs targeting these kinds of people, the people that we expect that when there's an emergency, they can support and contribute. So they need to be trained as part of the preparedness activities. For training institutions like a university, public health institutes, faculties of medicine, and all of that, we also need to teach the relevant public health students or global health students, public health research students on some of these practical approaches or practical applications in the field. So we need to bring people who have had frontline experiences, real-world experiences, to come and discuss some of these things and answer the questions. I feel that's the way to do it. Another approach really is through media programs where people can call in to ask questions and you can answer some of those questions. And that way you can also disseminate certain relevant information that can help to shape future planning for emergency response. So there are diverse approaches that you can make the difference. But we need to begin to create a pool of people who have had these kinds of frontline experiences to work together with people who are in the process. What I call them change agents, the younger change agents. We need to bring them together so they learn from each other, and that way we can produce people who are really more competent to operate in these kinds of settings I'm describing.
I'm allowed to follow up. I just want to find out, within the institute, how do you set that scenario and get students motivated to learn some of these practices within this institute if you were to set up things like that within the institute?
Okay, I'm already involved in some preliminary work already. I'm beginning to see students of global health now who are interested in emergencies and emergency preparedness or emergency related work, and I'm working with them on their projects, for instance, research projects. This afternoon, immediately after this meeting, I'll be joining the Global Health Students Association. They have a mentorship program this afternoon, and I'm one of the guests invited for that program, where I'm going to be answering questions related to humanitarian and public health emergencies and how they can begin to shape their career pursuits in the direction of interest to them. So these kinds of mentorship, information dissemination, knowledge sharing, supporting research projects, publications, and all of that. I think using the right expertise and field experiences, I think we can build a team within the institute that can be deployed, for instance, to anywhere in the world to support response, like some of the institutions in the United States are doing now. When we have emergencies in the field, like we had in Beira, we have people from Johns Hopkins University, we have people from Harvard, the Institutes of Public Health, teams coming to the ground to support the response and learn on the ground. And when they go back, they hold seminars and disseminates information from the response to others. So these are things we can institutionalize in the Institute. So it's not just the research and didactic approaches, or mentorship approaches, but we also need to have a system of deploying people to participate in some of these emergencies. And I think we can do that, really, working together.
That's great. Well, you know, Emmanuel, we are about to launch a new PhD in global health here at York University. And it's basically two streams, a dissertation stream and a more practical applied stream. And I think, you know, if you'd be interested in engaging with our students, something along, you know, in the applied stream there to support an organization and actually developing some practical solutions like supporting, you know, evaluation, planning, something like that. So maybe we should connect and see how, you know, what are some potential organizations they could connect with. And yeah, anyways, sounds great. Well, thank you so much for that very informative, you know, talk, helping us to be there with you in a sense to try and understand the kinds of situations that, you know, you're often faced with and how we have to address the problems. Very enlightening, and thank you so much.
Thank you.